and let me just express my gratitude for this kind of invitation, and that allows me just to share our preliminary data concerning the concomitant approach with the catheter ablation, atrial fibrillation, and the left atrial appendage occlusion. These are my disclosures. I will keep my presentation quite practical, and even if Dr. Bersma has already briefly touched up on the topic, I'd like just to add some piece of information that can be useful for the discussion later on. Let me introduce this nice 74-year-old lady with hypertension and symptomatic for atrial fibrillation since 2007. And as you can see, she had, in the last few years, progressively a quite complicated clinical scenario with several AF episodes. Amiodarone was started in 2008, plus the oral anticoagulation therapy. And she suffered from ischemic stroke in the same year, and at that time on TEE was the documentation of thrombus formation during therapeutic anticoagulation treatment. Pacemaker was implanted due to sinus dysfunction during anti-arrhythmic drug treatment. And in the following years, the antiarrhythmic treatment was more complicated because flecainide was added just to control amiodarone refractory atrial fibrillation. And then she had profuse intestinal bleedings requiring red blood cell transfusion. Amiodarone was discontinued due to severe hyperthyroidism and a total start. And then when she experienced a quite high rate atrial fibrillation, also had a cardiac decompensation, flecainide stops, ejection fraction went low to 35% during atrial fibrillation, and finally she experienced intracranial bleeding, so oral anticoagulation treatment was discontinued, and even at the same year she experienced TIA during aspirin. So in summary, we had to cope with a quite complicated clinical scenario, and obviously we had a quite long discussion how to pick up the right treatment options. Switch to dronedarone. At that time was just released in Italy. No one were crazy about this option. And you can obviously appreciate the other possible treatment options, AV junction ablation, and put the patient on aspirin plus clopidogrel, or just AF ablation, the occlusion of the left atrial appendage, or a concurrent AF ablation plus left atrial closure. So this was the choice. Also because you know that the catheter ablation of the atrial fibrillation substrate, even in the elderly patient, can be really much more effective in maintaining sinus rhythm than AV junction ablation, and for promoting a better quality of life and the functional left ventricle. There are another issue concerning which energy source can be used during catheter ablation, and we elected cryo-energy as a possible option for elderly patient. Cryo actually can promote some potential advantages, such as reduced procedural time, a potential reduce complications, mild sedation if you have to treat elderly patients, and maybe could be judged more affordable in elderly patients. Also, the histologic findings are quite different if you consider the minimal thrombosis promoted by cryo as compared to radiofrequency current delivery. And this could be crucial, especially just right after catheter ablation, when we need just to have a reduced tendency to thrombus formation. There is also a reason, at least for the electrophysiology standpoint, that when you carry out catheter ablation with a conventional approach, the radiofrequency with the catheter, usually you had just to go into the ridge between the left atrial appendage and the left superior, left inferior pulmonary vein in order to completely isolate the vein. The slide shows just an example of a 3D NAVX voltage map just before the purple color stands for electrical activity and the pre-ablation setting. And the post-ablation cryovoltage map reflects the gray area that is the extension of the isolation of the pulmonary veins. But please note that the ridge between the left atrial appendage and the left superior pulmonary vein cannot be reached from, by the balloon, and that's one of the reasons that we elected cryo. This seems quite controversial because if you look at the biomarkers of myocardial injury during cryoablation, here just highlighted in red, as compared to the radiofrequency current highlighted in green, it occurs that the myocardial disruption is much higher with cryo than RF. So there's some controversial issues that we need to take into account. Now, if you can just click on the left panel, please, just an example of the patient that I introduced you before, and the right, please, and just the right superior and left superior pulmonary vein isolation. Next, please. And here, the left, please, after we have isolated pulmonary veins, we switch to the identification, the right sides of the MPLATS device, and the positioning of the device into the left atrial appendage. Next, please. And over here, we have an example of the detachment, please, of the device in place, and a picture on the right of the 3D. Now, as far as the follow-up, the patient was discharged on a flecainide, and you can appreciate that the 3rd and the 6th month follow-up, the patient still on sinus rhythm, apparently with no clinical episode of atrial fibrillation, the pacemaker interrogation. The aortic therapy was reduced, the ejection fraction resumed into normal range, no GI bleeding, and fortunately a resumption of normal quality of life. So let's just ponder on what we have just presented. Is there a irrational to possibly and properly identify patients that could be considered potentially good candidate for a combination of catheter ablation and left atrial appendage closure? Usually patient with a high chance 2 or chance VAS score with impaired quality of life due to, please note, recurrent drug-resistant atrial fibrillation, and most of our patients were in a paroxysmal atrial fibrillation and not on a chronic atrial fibrillation, with a severe untoward effect on anti-thrombotic therapy or contraindication to this therapy. As we already heard before, untoward effects are related to frequent and untreatable GI bleeding or intracranial bleeding, and contraindications are here reported. And I like just to mention that there are patients out there with a high risk profile, like previous stroke or TIA during therapeutic antithrombotic therapy, or previous documentation of left atrial appendage thrombi with or without embolism. Now, let me just introduce another case just to be really on the clinical grounds. And this a quite younger patient than the patient that we saw before, 65-year-old, still a drug refractory atrial fibrillation in paroxysmal form with hypertension and suffering from ulcerative colitis. He had a quite unusual family history, a younger sister with ischemic stroke following a few hours paroxysmal atrial fibrillation, so we suspected quite propensity to develop ischemic stroke or thrombus formation due to some familiar predisposition. And the personal history account for a massive duodenal hemorrhage in 2008 while on antithrombotic therapy, and then also had a frequent intestinal bleeding. In 2010, he experienced 2 TIA and ischemic stroke in 2011, with the previous documentation over again of the thrombus formation on TEE. So this are just the list of the clinical presentation, and the case was done just a few weeks ago when the patient was on dronedarone, atenolol, and all the drugs here listed. Here, just an example of the electroanatomic map, and please know that it's not a CT scan, just a map, and the pre-elevation voltage map with the electrical activity, the appendage just in the anterior portion of the left atrium, and this is the post-ablation voltage map. The gray area again shows the complete isolation and quite a wide area isolation in the anterior pulmonary veins. Next, please. And here, the 3D electroanatomic map allowed to measure the mouth of the appendage. Was quite a fortunate case, just one big lobe of the appendage, and the measurement was quite close to the measure that we have got from the left atrial appendage angiography. And over here, we have done the pulmonary vein isolation. You can click. We had just the deployment again with the quite good positioning of the device into, next please, into the appendage. You had just to move on, I can from here. Okay, no, just move on. Okay, and here we have the picture on the TEE with the implantation of the device in the left atrial appendage with the circumflex artery just beneath the device and without any interference with the mitral valve leaflet. And here the 3D echo showing the same concept. Okay. Just to give you a brief capsule on patient clinical information, just to, what happened? Just the last slide, please. Okay, thank you. And these are just the first 8 patients that who underwent the combined approach. Already 4 patients are scheduled for next few weeks. And please note that we had the majority, the great proportion of the patient population on the paroxysmal atrial fibrillation. Just 2 patients had a short-lasting persistent atrial fibrillation. All patients had documentation at the echo TEE of left atrial appendage thrombus formation. 4 patients with intracranial bleeding and the GI bleeding was the major bleeding process in the patient population. The CHAS score, the mean value was 2.4. 75% were male, and at the 3rd month, 5 patients had completed the follow-up with 2 patients with a short paroxysmal AF recurrences medically treated. And before I go to my conclusive remarks, I'd like just to present this picture. This was a patient treated with a device with a left atrial appendage occlusion 4 months ago. At the time, the patient refused to have the concurrent catheter ablation for very frequent paroxysmal atrial fibrillation. He was okay at the 1st month. At the 3rd month, he came back to our observation just a week ago due to atrial fibrillation recurrences. And after 5 days atrial fibrillation on TEE, there is this quite unusual finding, but probably the best interpretation is a thrombus formation. It's quite hard just to tell if the thrombus is device related or just because the patient had a long episode of atrial fibrillation. Just I wonder if I could have carried out the procedure at the time, it would have been just much more better for the patient from the prevention. We don't know, but it's something that we need just to take into account. And now, I think that we need just to deliver a message. These are really a super selected patients, but I do really think that we need just to look for. Which are the goals? The goals are always the same. We need to prevent AF recurrences, especially in those patients with a quite high recurrences of paroxysmal atrial fibrillation, just to prevent cerebrally ischemic event as much as possible. So once you have ruled out other potential causes, carotid source or what else, please be alert to prevent recurrences in what I call drug recalcitrant atrial fibrillation. In whom? Again, in patients with already previous ischemic hemorrhagic cerebral accident during therapeutic anticoagulation therapy and evidence of drug-resistant AFib. Patients candidate already to atrial fibrillation ablation, but already with a previous stroke or TIA during anticoagulation treatment and possibly a tendency to thrombus formation in the left atrial appendage. And again, patients candidate to AF ablation with a clear contraindication to anticoagulation treatment, or patient with suffering with a severe liver or renal impairment. I will stop here. Thank you for your attention.
Thank you very much.